So today we'll be talking about the management of bipolar affective disorders and briefly about when to treat and when to refer. So about the diagnostic criteria, clinical presentation, those things we have already discussed in the last session. So the outline will be we'll briefly discuss about the assessment followed by pharmacological management. Mainly we'll discuss about the mood stabilizers and antipsychotics in the session. Briefly about bipolar depression. What are the indications for referral or IP care when you get a patient who's suspected to have bipolar disorder? How to manage some of the side effects and the psychoeducation to be done for the patient and the family. So in assessment, it is very important to ask questions about when you get a patient who has some symptoms which suggest mania or depression, or you are suspecting that this might be a bipolar disorder or it's one of your differentials. It is important to always ask if there have been any similar episodes or episodes of the opposite polarity in the past. If it has been there, or if it is somebody who has had more than one episode, then always ask about how the index episode was, because very often the trajectory kind of follows what happens in the index episode. What has the predominant polarity been? Have they got more depressive episodes, or is it predominantly manic episodes that they get? The duration and severity of all the episodes. How has the inter-episodic recovery been? How functional they have been in between the episodes? Any suicidal behavior at any point of time within the episode or in between the episodes? What was the violence and agitation like, if it was there? Has there been any seasonal variation in onset of symptoms? Because there are certain people who have more of manic episodes in a particular season or more of depressive episodes in a particular season. So has a seasonal variation been there? Have there been any features of rapid cycling, which is basically at least 4 episodes in a year? Details of the current episode, obviously most important. And then are there any psychosocial stresses or biological rhythm? So many times it is seen that people who develop a manic episode, many times we see that there is some sleep disturbance before that. Has there been any substance use before that? And sleep disturbance is something that very often precipitates an episode. Have there been any significant stressors? So again, that can precipitate either mania or depression. If the patient is on treatment, how good is the compliance? Is the episode because of drug default, or is it something that is a breakthrough episode? Because then you have to decide the kind of medication you give. Are there any comorbidities, be it medical or psychiatric? Has substance use been there? If it is there, then always inquire about, has the pattern changed right before the onset of symptoms or after the onset of symptoms? Physical examination and routine baseline investigations like the hemogram, blood sugar, lipid profile, liver function, kidney function, and the serum electrolyte. This is just a chart which has, it is basically a summary of the assessment that you do. So I'm not going into this right now, but when the PPT is uploaded, you can go back and just have a look. So coming to the pharmacological management, the mainstay of the treatment is mood stabilizers. We also use antipsychotics. So gold standard, as we know, is lithium. But today, for the purpose of this session, we'll not be discussing lithium because of the narrow therapeutic index, and it is slightly difficult to prescribe in non-psychiatric settings. But valproate, lamotrigine, carbamazepine, oxcarbazepine, and topiramate are also other medications which are given. Along with that, there are several antipsychotics which have evidence in treatment of bipolar disorder, including olanzapine, quetiapine, risperidone. Additionally, lurasidone is also there. So starting with valproate, valproate is efficacious both in acute mania and mixed episodes. There is also proven benefit when somebody has multiple episodes or there is rapid cycling. It is not as efficacious for bipolar disorder compared to lithium and quetiapine, but it can be given as a first line, mostly in combination with some other medication. It is beneficial in maintenance treatment. Most studies have found it to be superior to placebo when we look at somebody who has comorbid substance use or comorbid alcohol use. It is also useful in people who have comorbid anxiety or panic disorders, seizure disorder, as we know it's an anticonvulsant, and in migraine. So one advantage is that it has a reasonably wider therapeutic range, especially when we compare it with lithium. So how to start it? Before we start, reviewing the medical history is very important, and to specifically look for any hepatic or hematological conditions which might be there, since they might be complicated because of valproate side effects. In young women, always ask the LMP, and if there is any doubt, it is very important to get a UPT done. So pre-valproate evaluation will again include the same things: hemogram, liver function test, fasting blood sugar, lipid profile, and the anthropometry, since weight gain is again something that happens. So dose generally recommended dose is 15 to 20 milligram per kg per day. It can be given as a loading dose. So that is an advantage because we don't have to slowly build it up and can actually be given to people who have acute mania. So roughly it comes around to 1 gram to 1.2 grams a day. We can give it into two divided doses, or if the patient has a lot of sedation, then we can shift the entire dose to night also. So generally therapeutic serum levels that we see are roughly around 50 or 60 to 100 microgram per ml. This is to be taken after 5 days of starting the medication. And these are the trough levels. So we see them after 12 hours of the last dose. Generally, last dose taken at night and early morning before taking the morning dose. That is when the sample is taken. So when there has been a single episode, it is generally advised to continue it for at least 2 years. 5 years if there have been 2 episodes, and if there are more episodes, then usually it is given lifelong. So the main side effects that we see commonly are nausea, sedation, weight gain. Some people may have alopecia also. Liver dysfunction is something that may happen. So it might be a good idea to repeat LFT every 3 or 6 months. Teratogenicity is actually quite high, which is why we ensure that the woman is not pregnant if we are starting, because the neural tube defects can be as much as 2%. There are some serious side effects that are not as common as the others, but even then thrombocytopenia and leukocytopenia, pancreatitis are still a possibility. Coming to the next medication, that is carbamazepine. So this is efficacious in both acute mania as well as maintenance treatment. So the pre-carbamazepine evaluation will be same as valproate, but we have to focus on serum electrolytes, especially if we are prescribing it to some elderly person, mainly because the risk of hyponatremia is there. It is important to ask for history of blood dyscrasia and hepatic dysfunction in this also. So the dose is 400 to 1200 milligram per day is what is considered the appropriate range. We generally give around 800 milligram per day, starting with maybe 200 mg BD, and then after 3 days we increase by 200, and then 3 to 5 days we again increase by 200 milligram. Side effects that are commonly seen are sedation, cognitive impairment, minor hematopoietic suppression may happen, and GI distress. Dizziness, drowsiness, ataxia is something that can also happen. Generally, it happens when the levels are a little high, and I will discuss about it, what to do when this happens. Skin rash is something that is seen with carbamazepine often, and elevation in liver enzymes, failures of OCPs if given concurrently, weight gain and teratogenic potential, although less than valproate, but these are also things to be kept in mind. So the next is oxcarbazepine. This is a keto analog of carbamazepine. It has a slightly wider therapeutic index. So the risk of the hepatotoxicity is less, and overall induction of cytochrome P450 system is also less. So the drug-drug interactions are slightly better. Risk of leukopenia is also less than carbamazepine. However, it causes more hyponatremia. So for monotherapy, we generally give it as an adjunct with some other medication, but when given for monotherapy, we start with 600 milligram per day in 2 divided doses and increase every 3 days by 300 milligram per day. We generally give around like 1200 to 1800 milligram per day, but the maximum permissible dose is 2400 mg per day. As an adjunct, it is started similarly 600 milligram per day in 2 doses, but increased slowly. So increased every 7 days, but by 600 milligram per day, and can be given up to 1200. So the other drug is lamotrigine. So although it is actually approved for acute bipolar depression, both 1 and 2, it is generally given in combination with something because the uptitration is extremely slow. So in acute episode, it might not be the best drug as monotherapy. It has very good evidence for maintenance treatment in bipolar 2, and it is found to be more effective against depressive episodes than manic episodes. So very, very slow titration is needed. 25 milligram per day we give for 2 weeks, followed by 50 milligram for 2 weeks. And after that, we can increase by 50 mg per day weekly. So the side effects that we need to be cautious about are skin rash. And if that happens, you need to tell the patient in advance that this is something, if it happens, then you need to come back and inform us. The rare but more serious side effects are Stevens-Johnson syndrome and TEN, which kind of need to be kept in mind and would warrant discontinuation of the medication. So coming to antipsychotics, generally in acute mania, the first line antipsychotics that are approved are quetiapine, olanzapine, risperidone, ziprasidone, aripiprazole. For acute depression, quetiapine monotherapy has very good evidence. Along with that, olanzapine plus fluoxetine is one combination that is given, and lurasidone also has good evidence. In maintenance treatment of mania and depression both, quetiapine, olanzapine, both monotherapy as well as in combination with valproate or lithium are approved. Also, antipsychotics play a role in bringing down the aggression in the initial days. So very often when we start somebody even on valproate or any mood stabilizer, we start with some atypical antipsychotics also, given for a period of a few weeks, so 2 weeks, 3 weeks, 4 weeks, so that till that time the aggression can actually come down and the mood stabilizer also starts acting. We need to be cautious in long-term use though, because people who have mood disorder, they also have a higher risk of developing TD. So tardive dyskinesia is a risk, and that is why we don't prescribe it longer than necessary if we are giving in combination with a mood stabilizer. So bipolar depression, I think last time also we discussed, it is quite important to treat it because we often feel that mania is the more distressing part, mania is the more severe part because it's more destructive. But when we look at bipolar depression, it actually has a lot more dysfunction and the disability associated is more. The percentage time which is spent ill in a person who has bipolar disorder is significantly more for depression compared to mania. There's a high risk of suicide in bipolar depression. So the main goal for our treatment would be euthymia, improving the functioning, and to make sure that the person does not have a manic switch or does not go into a manic episode. So for this, quetiapine monotherapy and lamotrigine are the first line agents generally. Lamotrigine in combination with a mood stabilizer. And if breakthrough episode happens, then it is kind of important to assess the compliance, like I mentioned previously. So when to decide whether the patient needs to be referred to a psychiatrist or needs IP care? So for both mania and depression, whenever there is a risk of harm to self or risk of harm to others, so it can be due to significant agitation or violence, suicidal behavior, refusal to eat, or emergencies like catatonia, they always warrant IP care and therefore might require a referral. If the patient have comorbidities which make the outpatient-based treatment unsafe or ineffective, then also it is recommended that you refer the patient out. If the patient is not responding to first-line agents, so if you have tried giving, say, valproate and the mania is just not subsiding, or you have tried giving olanzapine and the symptoms are not coming down, then it might be a good idea to refer. If treatment refractory episode is there, like I mentioned, if the dysfunction is very, very severe and significant and the diagnosis is not clear, so if there are some atypical features which are, some of them might look like mania but are not 100% mania-like features, and in that case also the person may require neurological evaluation and such. So it might be a good idea to refer them. So coming to side effects, I'll mainly be discussing about the valproate and carbamazepine side effects. So the dose-related side effects for valproate generally are the GI disturbance, tremors, and sedation. And most of them actually may improve with time or improve with dose reduction. If the GI disturbance persists, you can always add a proton pump inhibitor. And if the tremors are there and they are quite bothersome, in that case, you can add beta blocker. Hepatotoxicity, thrombo or leukocytopenia, and pancreatitis, if they are there, then they warrant a discontinuation of the drug. If somebody has PCOD, either concurrent or developed after starting medication, although evidence for that is kind of controversial, or if there is significant weight gain, then we try with lifestyle modification. And if PCOD is there, then addition of metformin can be considered. For carbamazepine, diplopia, blurred vision, nausea, ataxia, generally if they are there, we try to reduce the dose initially. But if there is a skin rash, Stevens-Johnson syndrome, agranulocytosis, or hepatic failure, then it is best to stop the medication and manage the medical condition first. In severe leukopenia, we'll have to stop the medication, but if it is mild, we can wait for some time and see if it resolves on its own. Hyponatremia, again, similarly, if it is mild, we can actually manage with supplementation, giving sodamine tablets. But if we feel that it is low, it is severe, then in that case, it might be a good idea to stop the drug. So the last part is about psychoeducation. So when you get patient and the family and you think that the patient has bipolar disorder, what are the things that you need to communicate to them? So one thing is you need to understand what is their knowledge or understanding about what the illness is, how to treat it, and what is the prognosis going to be like. Tell them about the diagnosis. Discuss what are the symptoms. So when this episode happens, these are the symptoms that are that can be seen. If you feel that they are a little receptive, you can, in a very simplified manner, tell them about what causes the disease. You can give information about how stress management and having regular habits and a rhythm in their routine is important. You can give information about what are the different treatment options how effective they are, what are the side effects, and what is the duration of use. So I think it is also important to kind of discuss about how compliance is necessary and how an episode can precipitate again if the patient defaults on the medication. Course, long-term outcome of the illness, the problems regarding substance abuse. So if there is somebody who has been using something and then they come in a mood episode, then I think it might be a good idea to discuss that how using the substance or any increase in the substance consumption can actually precipitate another episode. So that also can be discussed. Discuss about the relapse, and very important, how to identify the early signs of a new episode. So if somebody who has a history of mania, they just start sleeping less, they are having some sleep disturbance or very minor irritability, then I think the family members can actually approach and ask before it goes into a full-fledged manic episode. And lastly, advice for lifestyle and dietary modifications, mainly because the patient is going to be on these many psychotropics. So last, this is just a summary of CanMed guidelines, which is basically Canadian network for mood and anxiety disorder treatment. So this is the most widely followed and accepted guidelines for the treatment of bipolar disorder. This chart basically tells about how efficacious each of these drugs is for which condition, including depression, mania, acute as well as maintenance phase, and how is the tolerability and safety profile like. So after the session, you can, whenever you get time, you can have a look and see. That will also help you in deciding the kind of medication you want to choose for a patient. Thank you.